Well, I've been working with BRCA1 since 1994, but even before that, was starting as a young scientist in the 1987, working with Henry Lynch, Gilbert Lenoir at the International Agency for Research in Cancer in Lyon, France, looking for breast cancer susceptibility genes. That was following families, looking through pedigrees, using pretty old techniques to identify the genes. 1994 was BRCA1, 1995 BRCA2. I played some role with both of those teams, and that was a really exciting time. But since then, since 1995, we've had 20 years researching, still on the same subject, towards getting to the goal where women who are found to have a mutation through genetic testing no longer are going to suffer from breast and ovarian cancer through prevention, through screening programs, through prevention, and also through better therapeutics, which leads to better survival, better outcome for those women who do get cancer. I think at this stage, we've learned a lot about it, and in the clinic, we offer genetic testing, and it's shown to be useful in several ways. I think our challenge now is to make sure the testing gets out to as many women as possible. The discoveries that we've made about prevention and treatment can only be put into use if we know that the woman has a mutation. And so ideally, we know the woman has a mutation well before she develops cancer, so we can take appropriate preventive measures. Or failing that, to have a mutation identified really early on after a diagnosis of breast or ovarian cancer is made, so we can use that information appropriately in guiding her best treatment. So our challenge in Canada is to try and see that everybody with the mutation would be aware of it. This is quite a challenge. I mean, generally we've been restricting testing to those people who have a family history, who are otherwise at high risk. But I think we have to make maximum impact, we have to get the testing as wide as possible, both accepted by the physicians, by the patients, and by the healthcare delivery system. Well, this is a wonderful honor for me. I mean, I've been working in the field for probably close to 30 years, since 1987, in fact, and nobody went into this in the 80s knowing 30 years later exactly what would happen. But for me, it's been a wonderful and a rewarding career, both because the science has progressed so rapidly, because we've been able to make really important changes, impact on the lives of women at high risk of cancer, but also because the wonderful community of scientists and patients and advocates and donors and supporters throughout North America and throughout the world has really come together around this issue and done wonderful collaborative work. And it's been a pleasure to be able to work with them, particularly many of the scientists at the Vassar Center here at the University of Pennsylvania. Well, I think we have to have better prevention, better treatment. But I think the first thing we need to do is get the genetic testing as widely out there as possible and accepted, so that we will be able to identify those women who have mutations, because they could take advantage of many of the strides we've already made, particularly in terms of prevention, preventive surgery. Secondly, I think we really should focus on finding an alternative to preventive mastectomy, that is a non-surgical prevention that will allow the women to keep their breasts and have a very low risk of breast cancer. So the risk of breast cancer for a woman with a BRCA1 or 2 mutations, about 70%. After the preventive mastectomy, the risk falls to about 2%, which is a wonderful advantage. It's a tremendous benefit for the women. But if we're going to be able to compete, let's say with a prevention that's non-surgical, a pill or a shot, in order to make it viable, it has to be very, very effective. In other words, to be able to create a medical treatment that could reduce the risk from 70% down to 2% would be an amazing discovery, but it gives quite a challenge. Otherwise, people will still be left with a bit of anxiety that says, well, perhaps I should stay with the surgery. That gives me the best hope. Well, I think they're doing a tremendous job now. I think, by addressing the basic science, the epidemiology, the clinical studies, as well as developing new therapies and understanding really what these cancers are like, how they respond to therapies and new therapies, really covers the entire range of of the clinical science and the basic science that I think we're going to have to address. I think, moreover, the fact that they not only focus here at the University of Pennsylvania, but have a wide-ranging program which offers scientists like me and others throughout the world the opportunity to have the finances and the resources available to pursue their own lines of research. It's really turned into a wonderful resource. As money's become harder to get with, because of government constraints, et cetera, it's wonderful to see a research program, and I think this is probably the only one that's focused on BRCA1 and BRCA2 and maintains that commitment over the years, over hopefully what will become decades, and so that this niche, this area, which is tremendously important, although it's only about 5% of breast cancers and 15% of ovarian cancers, gets accorded the attention and the funding I think it really deserves.